very happy to have my colleague, Dr. Bevin Cohen here to present one of her research projects identifying patients who are incapacitated with no evidence advanced directives or the surrogates. So Dr. Bevin Cohen is associate professor in the Brookdale Department of Geriatric and Palliative Care Medicine at the Icahn School of Medicine at Mount Sinai, and also the director of the Center for Nursing Research and Innovation for the Mount Sinai Health System. Bevin is trained as an epidemiologist and a registered nurse, and she has received her PhD and MPH in epidemiology and MS in nursing from Columbia, and her BA in public health is from the University of Vermont. Much of her research is related to palliative care and end-of-life care and infection prevention control. However, she also partners with clinical nurses and administrators on a wide range of topics affecting the practice setting. So I'm going to hand this over to Dr. Cohen. So we are going to collect the questions and comments in the end of her presentation. So you're welcome to share your thoughts through the chat. Okay, Bevin.
Thank you. Thank you so much, Jingjing, for the introduction. And I apologize that we have chosen a title that is quite a mouthful, and I stumble on it every time I say it. But we are going to go through sort of what it means and why we chose this language to talk about this group of patients that we call incapacitated with no advanced directives or surrogates. And I just want to begin, as I begin every long presentation, with an advanced apology that I have a terrible voice, and as the presentation goes on, I have a tendency to lose my voice. So if you see me drinking a lot of water, I apologize for the disruption. And lastly, a note that, I'm happy to take questions at the end, but if there's something when I'm on a particular slide that I've said that, needs further clarification, please feel free to jump in. I probably won't be able to see your hand if you raise your hand function, but if you just start talking, that's fine with me too. I'm happy to give any clarifications on anything I might have said during the presentation. So without further ado, I'll just note that this is funded by National Institute of Nursing Research, National Institutes of Health. And I do want to acknowledge this incredible team up front. I'm going to be talking about we throughout the presentation, the royal we. So I wanted you to know who the royal we are, because it's very much a team effort. And I will say, if you came to this presentation thinking that I would be able to impart any wisdom or methodological guidance on natural language processing, I hope you're not disappointed that that is not my area of expertise, but I did want to highlight everybody here and some of whom do have that expertise. So we've been working with Bob Klitzman, who is an expert in biomedical ethics, Aviv Landau, who is a social worker and a data scientist specialist, Margaret McDonald, who is our partner at Visiting Nurse Service of New York, along with Sasha Verges, who's been our research assistant, helping to recruit patients and other healthcare providers for our qualitative work. And of course, Jingjing Shang and Pat Stone, who you all know as the leaders of CIPC, and Jiyun Song and Max Topaz, who are the natural language processing brains behind this presentation. So I did just want to acknowledge everybody up front for their incredible contributions to this work. So getting started with talking about what does this mean, incapacitated with no evident advanced directives or surrogates? So we all probably have had an experience at some point with a patient who's been in our care. They lack decisional capacity for whatever reason, either when they arrived in the hospital or at some point during their hospitalization, they lost capacity. And the care team is not able to find anyone, either family, friends, either appointed through a healthcare proxy or just not appointed, but somebody who might know that person. The care team can't really identify anybody who could speak to what that person would want, given their current medical condition. And we all know that sometimes these people also lack advanced directives. So here we have a situation where the person can't speak for themselves about what they want their wishes to be. They don't have advanced directives telling the care team what they would want in a particular situation. And the care team can't find any surrogates, either appointed by the person or not appointed by the person, who could talk about sort of their wishes, their values, and what might help contextualize decision-making for that patient. So that's how we came up with this acronym, INEADS, INEADS, incapacitated with no evident advanced directives or surrogates. There's a small literature that exists on this topic, prior to our work. Sometimes patients in this group are referred to as unbefriended. That's a term that we saw when we were looking at the literature. We chose not to use that because it wasn't particularly descriptive and it felt a little, negative. So we came up with this as an alternative. But if you're familiar with the term unbefriended, they're probably very similar. And we're probably defining it very similarly. So just a little bit of background about, why we think this is an important topic to, think about and consider how we're making decisions for patients. We know that 65% of adults in the United States lack advanced directives. And at the same time, we know that, it's estimated between anywhere from 35 to 65%, depending on the exact population of hospitalized adults, are going to lack decisional capacity while they're in the hospital. We also know that the population is aging and living potentially longer with dementia or with limited decisional capacity. And we also know that social isolation may be rising, particularly among older adults who might not be living with family or connected with family or, an elected family of friends. So we know that the population of patients who are in needs potentially is large and potentially is growing, but unfortunately, there's really not a lot of information available about how big this population is or whether or not it's growing. So that's part of the impetus for this work. So a few questions that come to mind about these patients: how do healthcare teams actually make decisions for patients who are in needs? Who is involved in the decision-making process, and what guidelines govern the decision-making process? So are there any policies, either at the institutional level or sort of at the state government level or federal level, that assist providers with making decisions for these patients? Who is at risk for becoming in needs, right? So we know that, maybe patients currently have decisional capacity, but should they lose it and end up in the hospital, they might not have advanced directives or surrogates. So, who is this patient population who might end up in this situation? And lastly, like I mentioned, the prevalence, how many patients are in needs? We really have not a clue based on the literature. I shouldn't say we have not a clue. We have very few clues based on what's available in the literature. So all of the literature on this population is really based on either case studies or legal and ethical analyses. There are really, very few prevalence estimates because these data just aren't captured in any kind of structured data mechanism. And any information that we do have may be a little bit outdated. And I'll show you an example. This is, and please, if you are aware of other studies, please send them my way. We're always limited by what we know and can find, but this is a study conducted, actually it's two separate papers conducted by White et al. In 2005 and 2006. And if anybody's interested, I can give you the reference afterwards. But this is, it's an older study at this point, 20 years old, conducted in a urban public hospital, a single ICU, during the time sort of before MOLST and POLST was, operationalized. And this, sort of short-term study found that 16% of patients in this context fell into this category of in needs. They didn't use that term, but, so that basically met that definition. And I think, for those of us who, may have had experiences, in acute care in the New York environment, to me, this does seem a little bit high. So, I was curious how, other data would match up with this estimate. And this, I should say, I believe it's a public hospital in San Francisco that had a large population of, homeless patients and people who might be more at risk of not having family members and not having advanced directives. So really, this is one of the only, studies to really look at prevalence that I'm aware of. And like I said, it is a little bit old and it just has some limitations just based on its size. So that brings us to sort of the aims of our current study. The first aim is just to simply determine the prevalence and the characteristics of adults who are in needs in an acute care setting using natural language processing. And that aim in the big green bubble, that's the one that this presentation is going to be focusing on. But I did just want to mention that we do have, several other aims that we are, in the process of working on. And, hopefully, in the future, we'll have an opportunity to present those as well once we have some, findings there. So the other pieces of aim 1 are to determine the prevalence and characteristics of adults who are at risk of becoming in needs. And we're going to be doing that again using natural language processing, but looking in a set of home care notes from the Visiting Nurse Service of New York. And with all of these notes, but particular to the acute care, on the bottom, you could see we're going to also be doing some content analysis in the future of the clinical notes and the documentation that's available, just to try to figure out for patients who we've identified as potentially being in needs based on the natural language processing, trying to understand who is involved with the decision-making for those patients, what's the timeline for the decision-making, so were there major delays based on, not being able to find the patient's information and needing to involve other parties. What are any policies that might be referenced, and how the patient's clinical characteristics and personal characteristics might factor into the decision-making process. So again, just gleaning what we can from the clinical notes of patients that we identify as being in needs using NLP. And aim 2 is a qualitative aim to just explore the phenomenon of in needs from both the clinician and the patient perspective. So for this, we're in the process of conducting interviews now with both hospital and community-based healthcare providers and also members of hospital ethics boards to understand sort of the provider professional perspective on this subject. And we're also going to be doing and are in the process of doing interviews with patients who are living in the community who are at risk of becoming in need. So again, these are people who we're identifying in partnership with Visiting Nurse Service of New York, patients who are on the post-acute care roles of Visiting Nurse Service. We're doing interviews with those patients to try to understand, a little bit more about, their understanding of advanced directives, who they think will be making decisions if they are unable to do so. And for the clinician side, we're asking about barriers and facilitators to formalizing and standardizing the decision-making process for in-needs patients, both in the acute care setting and in the, the community setting. So that's the big overview of the study aims. But like I said, the main place that we'll be focusing today is up here on top in the green, determining the prevalence and characteristics of adults who are in needs in acute care using natural language processing. And I will pause for my first water break, excuse me. Okay. So study data source. So for this study, we're using the Medical Information Mart for Intensive Care 3, or the MIMIC 3. And this is de-identified data for over 50,000 hospital admissions, representing over 45,000 patients who were admitted to any intensive care unit at Beth Israel Deaconess Medical Center in Boston. These data, and specifically the MIMIC 3, are from 2001 to 2012, though I do want to note they have since come out with I believe a MIMIC 4, which has, I think, more data elements and newer or more recent years of data. So this is a publicly available de-identified data set that we were able to access for the purpose of this project. So for our analyses, we excluded patients who were less than 18 because we were specifically looking at adults. So our analyses included 23,000 hospital admissions for close to 18,000 unique individual patients. So the data elements that are available in the MIMIC-3 include a combination of structured data from the electronic health record and also electronic clinical notes. So the structured data, all the things that you would expect, demographics, vital signs, labs, procedures, medication, and discharge disposition. But the thing that we were really using for this study is the electronic clinical notes. So there were a variety of clinical note types and subtypes, depending on who's writing them and what the purpose of the note is. So we included case management, consultation, discharge, nursing, nutrition, physician, rehab, respiratory, social work, and general notes, which are the admission, death, procedure, and progress notes. We excluded any categories that we thought would be very unlikely to contain any information related to somebody's in-need status, such as like radiology, pharmacy, ECG, those types of notes that are very technically oriented. So in total, there were over 400,000 notes included in our analysis. And I did want to point out that the vast majority of them, 70%, came from nursing. So now I'm going to give a little bit of an overview of the NLP methods. And if you didn't catch, as I said this in my introduction, I will say that this is a layperson's, understanding of natural language processing. I will give you the steps that we took, but if you have any super technical questions, I will refer you to my colleagues. This is simply an overview of the process, and I am going to go through each step sort of step by step in the coming slides. But the overall idea is that first we're going to be just with our minds identifying some concepts and terms related to all of the concepts that we're interested in picking up. Then we're going to apply the the NLP algorithm piece of this to create a language model, and then find synonymous or similar expressions in the larger data set. And then we do some evaluation of the NLP algorithm. Basically, we have human reviewers make a gold standard sort of test set, and we evaluate the NLP versus the human review to see how well it did in picking up each of the categories. So I'll go through each of one of these in a little bit more detail, but this is just a nice overview and a figure that's beautifully made, not by me. I don't know if it was by Jiyun or by Max, but it's very beautiful. So I wanted to share it with you. So the first step, in a little bit more detail, we wanted to identify concepts related to the three main domains of INEADS as we have defined it. So again, those big buckets are decisional capacity, advanced directives, and surrogate decision makers, right? So whether you have or lack each of these three categories. Then we created subcategories within each of these three domains. And again, just using our minds to figure out what makes sense to look for and include. And then we grouped subcategories based on whether we thought they indicated that somebody has a reduced potential for being in needs, i.e. it's protective, or whether it meant they would have an elevated potential for being in needs, meaning we thought that this really put them at risk. So in the second step, we developed a preliminary lexicon for each of the subcategories that we identified. And we did this through a couple different methods. The first is using some standardized terminologies, either from the SNOMED, Systemized Nomenclature of Medical Terms, or ICD terms, classifications, or International Classifications for Nursing Practice terms. But really, we did a lot of this through reviewing the literature and looking at terms and expressions that were associated with this patient population. And also we relied a lot on our expertise and experience with patients. It was really nice that our team includes expertise and training in a variety of different disciplines. So we have nursing, medicine, social work, bioethics, public health, and informatics. So we felt that that gave us a nice, round place to work from in terms of identifying potential terms and expressions associated with each of our subcategories. So in steps 3 and 4, and here's where it gets really technical, but I've tried to boil it down for my own mind into 2 or 3 sentences to understand. So first, we created a vectorized language model. So this used the Nimble Miner software, which you can run on R. I believe it's actually created by Max Topaz, correct me if I'm wrong, but it's something that's freely available to the public. And this is the software that is used to create a language model called Word2Vec algorithm. And this helps to facilitate identifying synonyms for our list of preliminary terms that we came up with. So we came up with an initial list, and then we need to apply an algorithm in the data in order to come up with additional terms and expressions that might be related. So that's the next piece, which is implement the interactive vocabulary explorer. So we have the algorithm identify similar words and expressions in a big body of text from those clinical notes. And then as human reviewers, we look at what that algorithm identified and determine whether we think it does or does not represent the concept that we were hoping to pick up on with the terms in that category. So we either keep it or reject it based on our human review. So in step 5, I mentioned previously, we develop a gold standard reference to evaluate the algorithm performance. So for this, we randomly selected 300 notes from patients who we thought might be at higher risk for INEADS. So we did this specifically from patients who have a history of psychiatric disorder or who have infections that might be associated with IV drug use. We tried to sort of hone in on patients who seem like they might be at higher risk for being in this category, and we selected the notes from those patients. Then we did a human review of those notes to identify text for each of the subcategories that we identified. And don't worry, I will be telling you what those subcategories are in a subsequent slide. So we had 2 reviewers review each note, and we had 1 tiebreaker if needed. And in the end, we found that the system did have pretty, not the system, our system, our human system did have pretty good intra-rater reliability at the note level for determining presence or absence of an INEADS category. So if 2 of us were looking at the note, we had a pretty good sense, a pretty good match of feeling that the patient, the person either did or did not have a specific subcategory. Okay. So now on to evaluating the NLP performance. So this is how we applied the NLP algorithm to that 300 note gold standard test set. So we applied the algorithm and then calculated precision, which I'm an epidemiologist. So for me, I had to figure out what does this actually mean. It's similar to positive predictive values. So it's the number of true positives over true positives plus false negatives. We also calculated the recall. So this is similar to sensitivity, if you're more used to those terms, and it's the true positives over the true positives plus the false negatives. And then from that, we calculated the F score, which is a weighted harmonic mean of these 2 calculations, precision and recall. So this is how we determined how well the NLP algorithm was doing at identifying each of the subcategories that we wanted it to try to identify. And then once we did the gold standard testing, we applied the algorithm to the entire set of 418,000 clinical notes, and the sort of answers or information that we were hoping to get out of this is what is the proportion of clinical notes that actually include words or expressions in any subcategory, right? So overall. And then we also wanted to know, what's the frequency of each subcategory, each of our categories at the admission level. So for a patient admission, how many of them had each one of these picked up in a note? And then, of most interest to our aim is establishing a cohort of patients who we think might be INEADS. And I'll give a little bit of definition in the subsequent slides about what this means, but basically having, some subcategories that indicate a potentially elevated, risk of being in needs. And we also wanted to establish a really high likelihood group. So these are people who had many subcategories indicating high potential for in needs. And it will make a little more sense when I tell you the subcategories in a subsequent slide. But these are sort of our main goals with the NLP. Okay, so here are the long promised categories. So for our first domain, which is surrogate decision makers, and this was our largest number of categories in this domain, we found or we identified or thought of a number of different categories that would indicate reduced likelihood of being in need. So this is being married, being partnered, having living relatives, and we specify here unknown involvement, right? So it's something that maybe a son or a daughter or somebody is mentioned in a note, but we don't know whether that person is involved or in the country or how much they can be involved in decision making, but we know that the patient has someone. Caregiver support, living with or close to others, community connection. So this one I'll just note is about, having neighbors or friends or belonging to, senior centers. Sometimes those things come up in the notes. Religious connection. So again, some evidence that maybe they, have a clergy member or they attend some kind of a congregation. And surrogate decision maker identified. So here is where we were able to find not only that a family member or friend or somebody exists, but that we could find evidence that a team member actually was able to contact them or spoke to them or involve them in a decision. So all of these, and the smaller text next to them just gives sort of examples of the types of terms. There are many, many, many more terms. I just pulled out a few. But these are the types of terms for each of those categories that we thought would indicate a reduced likelihood of being in needs for the surrogate decision maker category. For elevated likelihood of in needs, we identified 4 subcategories in this domain. So the first is being unmarried. And again, not that this would necessarily mean you are in needs, but it could, indicate elevated versus, protective effect. Living alone, transitionally situated. So with this, this is what we mean to capture somebody who might be homeless or may have been incarcerated, something like that. And surrogate decision maker unidentified. So when it's clearly written that the care team was not able to make contact with a family member or a friend, that an attempt was made and it was not successful. So these are our surrogate decision maker domain categories. There are far fewer in domain 2. So domain 2 is advanced directives. So we have 3 that we thought would indicate potential reduced likelihood of being in needs. So that's palliative care, hospice, and advanced directives available. So advanced directives available are when there's some kind of text indicating that there's a healthcare proxy or something on file. The hospice and palliative care, we did put these in the reduced likelihood of being in needs category because generally speaking, if a decision has been made for hospice or for palliative care, it means someone was involved or consented or in a discussion about this with the patient. So we thought that this would be more indicative of having a reduced likelihood rather than an elevated likelihood of being in needs. And the elevated likelihood category here is advanced directives unavailable. So if there was any text indicating that the patient didn't have a healthcare proxy or did not have an advanced directive, we picked these up in this category. And domain 3 was decisional capacity. And here you can see there's only one category, and it does indicate an elevated likelihood of being in needs, and that is lacking capacity. So whenever there was any type of text that indicated that the patient lacked capacity to make decisions for themselves while in the hospital at any point, they would be picked up in this category. So here's a slide just summarizing how well the NLP algorithm did with picking up each of these categories. And it also gives you a sense of how frequent each one of these categories was documented, that we were able to pick up, I should say, relative to the other categories. So you could see the most frequent subcategory that the NLP was able to pick up was living relatives with unknown involvement. So again, this is, a son or a daughter, or somebody is mentioned, but there's no context to indicate whether or not that person is actually involved with the care or on site or in phone communication with the care team. And you could see I actually highlighted this one in red because we only had 2 categories that the NLP really had a hard time picking up on, and you could see that with the F score over in the last column. So the F score, again, is the overall sort of harmonic mean that tells us how well the NLP is doing in terms of picking up these different categories. And the 2 that really sort of underperformed or performed less well than we would like to see is the living relatives with unknown involvement, the largest category, and also surrogate decision maker unidentified. So these, it's not surprising, I think, that the NLP had a difficult time, just because I think it's very nuanced to try to pick up on, okay, we're talking about a family member or, an involved person, but it's very difficult to figure out using an algorithm, not human review, sort of what that person's involvement is. So those 2 sort of underperformed where you would like to see the F score to be, but the rest of the categories, did relatively well. I'm assured by my colleagues who know more about this than me, that the performance was good, and the overall performance, the overall F score was 0.83, which again, I'm assured is a solid performance for the NLP algorithm. So to answer some of our questions about sort of the frequency of the clinical documentation and how often are we seeing all of these concepts come up in the notes. At the note level, overall, we saw that 50%, half of the notes, contained at least one subcategory. So we picked, the NLP algorithm was able to pick up these categories in about half of all of the notes that we reviewed. At the admission level, 81% of admissions had clinical notes that included at least one subcategory. So again, we're looking, we look both at the individual note and then also across a patient's entire admission, looking at all of those notes, 81% had documentation in at least one of those categories that was picked up by the NLP. So consistent with the proportion of each type of note in the data set overall, it's not surprising that we found 68% of notes that had at least one subcategory were nursing notes. And remember, 70% overall were nursing notes, and 18% were physician notes. So this pretty much, aligns well with, the overall documentation. And the subcategories that were that indicated elevated potential for INEADS were most likely to be documented in consult notes and least likely to be documented in nursing notes. So it's sort of interesting, we found, the most categories in general in the nursing notes, but when we're looking specifically at things that we think indicate an elevated level of being in needs, they were actually less likely to be found in the nursing notes, more likely to be found in the consult note, which does make sense. You would think that there, could be more, people called in for cases like that. So sort of, it's a good indicator that it tracks well with our logic. But if you have other thoughts, please let me know at the end. So this is the frequency of admissions that contain, each one of our categories. So again, this is at the admission level, not the note level. So living relatives with unknown involvement is still, by far the most frequent. Lacking capacity is the second most frequent. And I won't read everything all the way down, but I'll just show you at the very bottom, people who, picking up on people who are transitionally situated, whether or not somebody has caregiver support, relatively, there were few notes that picked up on those concepts, which, again, is not so surprising given, that wouldn't necessarily come up in the vast majority of our notes, which are nursing notes. I did want to point out that we were only able to detect 9 instances of not having advanced directives using NLP. And, this sort of suggests a couple of things, but one is, there may be a benefit to looking at the structured data as well, because it could be that, in a real life EMR, there is a tick box or some kind of check box, or, a field that's either full or empty with an uploaded document with advanced directives. And it's just not something that's going to be, sort of written explicitly in the notes. So just wanted to give you sort of an overall sense of, how frequent each one of our categories was. So now on to what I consider the exciting part, the more interesting findings sort of related to our actual research questions. So we found that 76% of admissions included at least one subcategory that indicated either the presence of advanced directives or surrogates. So meaning that, those patients would not be in need, right? Even if they didn't have decisional capacity, they have either advanced directives or surrogates who can give the clinical team, some kind of a clue into, what types of decisions that patient might want to make or have made on their behalf. 30% of admissions contained at least one social subcategory indicating elevated potential for being in needs. And I underline social because I just want to point out that we didn't include the lacking capacity subcategory here. We were really interested in, because obviously patients' decisional capacity can be fluid. They can have it and lose it. They can, not have it and regain it. But we were really interested in sort of the social piece that's sort of, outside of the patient's condition. So those categories are being unmarried, living alone, transitionally situated, surrogate decision maker unknown, and advanced directives unavailable. So 30% of our patients had at least one of these subcategories identified. So we threw them into a group called possibly in needs, right? Or possibility of in needs, right? They may have an elevated likelihood of being in needs, but they don't have necessarily a strong possibility of being in needs. Less than 1% of admissions, 81, met the criteria for high likelihood of being in needs, meaning that they had at least 4 of these 5 subcategories identified. So they had either 4 or 5 of these: unmarried, living alone, transitionally situated, surrogate decision maker unknown, and advanced directives unavailable. 79 had 4 and 2 had all 5 of these subcategories. And for this high likelihood of in needs group, because this is really who we're most interested in detecting, we manually reviewed 10% of these notes, which is 10% of the admission. So all notes in the admission, which is 8 admissions. And from our human review, I did the review along with Aviv. Each of us reviewed all of these. And we did find from our human review that all of these really did appear to meet the definition of being in needs as we're defining it. So we did a little validation on this, this cohort of high likelihood of in needs. So I did just want to show, we didn't talk about the demographics of the whole cohort yet. So you can see the column that says all admissions is telling us, sort of just about the, the whole cohort in general. And I think it is reflective of what you would see in, an East Coast big academic medical center. But, we did want to just highlight the differences between the whole cohort versus the patients that we think, have a possibility of being in needs based on having, at least one of the categories identified, and the patients who we think have a high likelihood of being in needs based on having 4 or 5 of the categories identified. So we could see that, the people who were more likely to be in needs, more likely to, die during the follow-up period, which I believe is 4 years following discharge. They were more likely to expire, while hospitalized. They were more likely to be male. They were more likely to have come in for an emergency versus an elective procedure. And again, that tracks, right? They might not have been expecting to, be in the hospital and have decisions, make decisions or have decisions made on their behalf. And also, somewhat more likely to be, have Medicaid insurance versus being a private self-pay patient, or excuse me, a private insurance patient. So, all of these are sort of, tracking with what we see in the literature about who we, expect these patients might be. So, it was, again, good to see as a check on our NLP algorithm that the patients that we identified as, being either possibly or highly likely to be in needs sort of tracks with what we would expect based on what we know from the literature. So, of course, I do want to touch on, limitations of the, of this part of our project. The data is, of course, limited to a single academic medical center in a northeastern city, right? So we know that there could be differences in the local patient population. There could be differences in local documentation practices or local terminology. So all of this would sort of affect the performance of NLP, and also what types of categories it may or may not be picking up on, and what types of vocabulary words it would be using. So this might not be generalizable to every setting. We also had a relatively small number of annotated notes used for the training and testing set. So it's possible that, the model could have missed some rare but potentially relevant expressions. There is some ambiguity and heterogeneity for the expressions in each category, and I'm sure, or I'm not sure, but I would not be surprised if, while I was presenting those categories, you were thinking, I'm not sure if I agree with that analysis. So I'll just give you, we had a lot of back and forth about what should or should not be a category, and what should or should not be included as a term, and whether the category means that someone is, at higher or lower likelihood of being in needs. So I'll just give you a few examples of where the ambiguity might lie. Living relatives with unknown involvement. This likely includes relatives who are actively involved and who are not actively involved in the decision making, but there's simply no way that the NLP would be able to have sort of enough documentation to really further specify this and help us understand, the level of involvement with those people. So that's why, they're sort of in a category by themselves. We don't, yes, they exist, but we're not sure, what they mean to this patient. The second, and I think I mentioned this previously, but palliative care and hospice, after a lot of back and forth discussion, we classified these as potentially reducing the likelihood that someone is in needs, because typically these, decision to go into hospice, decision to have palliative care, these decisions are typically done either with the input of a patient or with the patient surrogate. So we thought that, it would mean that they were going to be more likely, to either have someone, to have someone in their life or to have some advanced directive. However, the NLP could have detected documentation where, the care team was referring a patient to palliative care or referring them to a hospice because they needed more, in-depth advanced care planning. So they were, referring them for a consultation for that reason, and maybe they could have been more likely to be in need. So again, some of the ambiguity that, we had to consider when figuring out which categories to put these in. And lastly, we excluded data in structured electronic health record fields. And one of the reasons I think for that is the data set that we were using didn't really have a lot of fields included that we thought would be relevant to include. But if we were to do this sort of locally with our own EHR data, there's probably some other elements that could be interesting, such as, do they have a contact person? Do they have documents uploaded for advanced directives? Do they have DNR, DNI, orders made, et cetera? So in a future study, it would be great to really sort of explore how NLP could work in conjunction with, the structured or the semi-structured data to get an even better picture. So lastly, implications and what's our next steps. So, overall, I think, we could agree that we found a relatively small absolute number of patients in this data set, only 81 patients out of, almost 30,000. But, across the United States, the number of in-needs patients is probably worthy of further exploration, because we're looking in one medical center, and we may be missing some people, right, due to the limitations of NLP. If you replicate this at every hospital, it's worth exploring sort of how decisions are made for these patients and how the decision making can be improved. And it's also worth considering whether NLP can be used sort of in a proactive way to identify patients who, might be at risk of being in need, or identifying them early when they come into the hospital, so that maybe they can have, social worker or ethics assigned right away to be helpful, from the beginning with making those types of decisions. So next steps, I mentioned this in the beginning, but I'll just sort of recap what else we're working on this project. So we are going to repeat, the NLP process to try to identify patients who are at risk of becoming INEADS in the home care data set with Visiting Nurse Service of New York. So we're actually almost done with the NLP process for that. So hopefully we'll have those results to present soon. We're also going to be doing a content analysis of the clinical notes for patients who are in INEADS and are at risk of becoming INEADS, just to get a better understanding of the decision-making processes and the timelines and who's involved. And lastly, we are conducting qualitative interviews to just further explore this phenomenon and, understand better the decision-making process for these patients. And you can see on the bottom our shameless plug, we're recruiting, we're recruiting patients through Visiting Nurse Service of New York, but we're recruiting healthcare workers or any professional who's involved with these decisions. And I know we have a lot of them on this call. So, if you have a lot of insight into this topic and you would be interested in providing a research interview, please feel free to reach out to me and we'll get you over, the official, recruitment materials. And then if you're interested, we can schedule, time for you to, provide us with your insight. Yeah. So I think that is all she wrote. Yes. That's all I have, but I'm happy to take any questions.
Okay, great. Thank you so much, Dr. Cohen. So do we have any questions?
Is Pat, do you have a hand up? Is that a hand?
I do.
Okay. Like, what is that thing? Okay, it's a hand, yes.
Well, this is really fascinating. Do you think that, compared to the literature, that it seems like it's less, we didn't find as much.
Yeah.
And so it makes me, do you think it's really a phenomenon that's happening less, or it's the process of using the NLP and really wasn't that good at doing it?
Something that I've definitely thought a lot about. It's a really good question. I think, the particular study that I showed, sort of on that beginning slide that had an estimate of 16%, I think the reason that feels really, really high relative to what we found is sort of twofold. The first is that was done through a prospective data collection in a clinical setting. So the person who, conducted the study, I believe, I don't want to misspeak, but I think he wasn't attending in the ICU, and actually collected that data sort of live and in real time. And, so was able to collect that granular data in a way that even with natural language processing, I don't think we'd be able to pick up on. So I do think one problem might be just sensitivity of the algorithm to these types of concepts. But the other piece I think that's relevant is I think that particular hospital really saw an outsized number of those types of patients just because of the type of hospital that it was and the type of patients that it served. So I think that's another reason, sort of outside of the artifact of our method, I think that they might just have a higher proportion based on their patient population. So it's definitely less, and it's hard to say how much is due to NLP versus, how much is due to the patient population, and, maybe the truth lies somewhere in between. But that's why I think it'll be really helpful, in future iterations, if we do explore more, to try to include not just the NLP, but to try to include some other, elements that can help us really be super sensitive about picking up on all these patients.
Super, thank you. I have more questions, but so does somebody else.
I think I can see, is it Miranda? Do you have a hand up?
Oh,
sorry.
yes.
I'm just reading your name. Yeah.
Yeah, I have two questions. The first is, I'm not sure whether I have noticed that the data set was based on Mimic3, or you have included some real world data sets. Like you mentioned that you have a data set that you collected from a home health center.
So thank you. Great question. I'll clarify that the data that we presented, that right here, all of the findings that we just looked at, that's only from the Mimic3, but we will be looking, we are in the process of looking separately at a separate data set from Visiting Nurse Service of New York. So those patients, what we're hoping to find there is people who are at risk of becoming in needs because, right now they still have decisional capacity. They live, independently in the community or partially independently in the community, but, maybe they don't have, the nurses and social workers have identified that they don't have family, they don't have support, and they don't have advanced directives. So we'll be looking in that data set to answer that question of sort of who's at risk of potentially becoming in needs if they end up in the hospital and lose their decisional capacity.
Okay, thank you so much. And I think it's a very good choice because in artificial intelligence model training, so the results of external validation is very important to evaluate the generalization of our model. I think it's a very good choice. And the second question is about the NLP training technology. I've noticed that you used the word to vector like a
Miranda, you froze up.
Yeah, I just want to point out Miranda is our upcoming PhD student. She is in China, she's in Beijing. So it's time difference. This is like 2 a.m. in her time. So the internet connection may not be very good. Miranda, you may type your question through the chat.
Miranda, you may type your question and I will email it directly to Max, who can answer it much better than I can.
Yeah.
I started hearing Word2Vec algorithm and I said, we're going to pass this to Max anyway. So, but thank you for the question.
But Bevin, I had a question about, it's a great presentation. Thank you. Really fascinating to see the results coming into fruition for that. So in your mind, when you think about that, right? So we've developed this NLP algorithm that identifies high-risk patients. What's going to be the next step? Like, how do you apply it to clinical practice? How is it going to be useful to clinicians?
Yeah, it's a really good question. And we sort of previewed this question in our last team meeting, sort of trying to think about what is the next step with this information? And I have spent a lot of time thinking about that over the past, couple months and weeks as we do this. I don't think the question is answerable for me personally until we have the qualitative data. I'm looking forward to, sort of the next steps, looking at, both the content analysis of the notes to figure out sort of how these decisions did end up getting made for the patients. And then also looking at sort of our qualitative data to figure out, from both the, the patient perspective and the clinician perspective, how we, what might improve, patients getting care that's aligned with their goals and wishes, particularly if they are sort of in a, more vulnerable state, in that they don't have family, nearby or, family that's involved in their care. So I think, potentially there is a role for, NLP or a role for some other type of intervention. But I think until we have the qualitative work to pair with this, I'm not 100% sure what it is. That's my honest answer. I wish I had a better answer, but I think the answers will come as we answer some of the other aims of the grant. So I apologize for my non-answer, but it's in truth how I feel.
Bevin, one other thing that I'd like to see if anybody else has any input on, because I remember when you came in and told me about, this idea, and I was so appalled by the term unbefriended. I'm like, we can't call it. I mean, how can you call somebody unbefriended? It just bothered me. But that is the term in the literature. So, I'm interested, some of our palliative care experts or anything, what do they think of INEADS? And I mean, obviously you're going to have to use a tagline, unbefriended, also in mesh. So it gets there, but it's just such a strange term, unbefriended.
Yeah, Pat, I totally agree. And that's, I think we we were on the same page that it felt a little wrong, it just didn't, it didn't sit well. And the truth is, we did come up with this alternative that's at least more descriptive. I don't know that it necessarily sits better. So I agree. If, I'm totally open to anybody who, on the call, might have other suggestions or feelings about, how this term compares to the other, and if there's anything better that we should be using.
Yeah.
So either now, or if you think of something, you can email at another time.
Yeah.
If you happen to think of something. But yeah, this term will be new when we publish the first paper. This term will be sort of new to the literature. Everything else previously.
Yeah, you got to put a mesh term in there,
Yes.
unbefriended, so people will find it.
Yes, exactly.
Yeah. And I do encourage you, because Russ Portnoy, which I think I put you in touch with in the past, and he's presented in the past, he said he was working on some of this work with somebody else. I'm not sure exactly what it was, but he talked about it. So you might want to catch up with them to find out who that person is.
Yes, that's a very good point. I will. Yes. And it looks like, sorry, I see Miranda put the question back in the chat. So if we have 1 second, I'll throw it out to Max because somebody else might be interested too. The question is maybe Word2Vec does have problems in ambiguity and contributions to real-time update. Do you have any plan in the future work like adopting other methods like BERT or other models? And since I don't know who BERT is, Max, would you please?
Yeah. BERT is not a character from Simpsons. That's a NLP model, one of the advanced models. So thank you, Miranda. These are great questions. I think it's very appropriate to use something like BERT in the future, right? We can talk about that more when we have time. But when we implement this NLP, right, then we will see, how it will turn out actually, what the needs are going to be, right? And I guess we will have to think about some alternative, more advanced NLP models that are out there.
I think we have another question. Do we still have time? We still have 2 minutes. From Maria Gagan. She's our clinical faculty, and she sent a question to me with is more like a comment. We need to address the cultural difference and understanding regarding the advanced directive. So Bevin,
Yeah, I agree with the Kyle. Just say I definitely agree with the comment. I think that comes up a lot in different projects that I'm involved with, and I'm sure that we're all involved with. From the NLP perspective, it's interesting because we're actually not able to pick up on those types of differences. We don't really have that granular cultural data, and also the documentation that we're reading and reviewing is really, just from clinicians, and it's not sort of, written by patients or family members, sort of with that perspective involved, in mind. But I will say that for our qualitative work, I know, Aviv Landau, I'm not sure he's on the call, but he's been leading the qualitative interviews, and I know that this is something that's already come up with several of the interviews that he's done with social workers at Visiting Nurse Service. So it's definitely something that I think will be addressed in the the other aims of the project, although we weren't really able to address it with the NLP. But I think it's a thank you for raising the comment. It's definitely something that we need to keep in mind.
Okay, great. So it looks like time is up. Do we have our next announcement for the next seminar? Bridget, do we have flyer? Thank you very much, Bevin, for the wonderful presentation.
Thanks, Bevin.
Thank you for the opportunity to present and for all of the wonderful colleagues who have been involved.